Good morning, all. Am I audible?
Yes, sir.
Okay, so today we'll be learning about what is pharmacodynamics. So we have two important subdivisions how the drug will act in the body. So one is the pharmacokinetics and one more is the pharmacodynamics. So pharmacokinetics, mainly we all know it is the ADME, that is absorption, distribution, metabolism, and excretion. In a similar way, pharmacodynamics is what the drug does to the body. In simple terms, pharmacodynamics is what the drug does to the body. So here on the first slide, I have put a receptor. Okay, so it is a VGPCR or the receptor with the ion channel here. There are 5 subtypes which you can see: alpha, beta, gamma, delta are all the components of this receptors or a typical ion channel receptor. So we'll move on to the next slide. So the next slide here shows what is the difference between the pharmacokinetics and the pharmacodynamics. So we form a dosage and the drug enters the plasma or the site of action. From the site of action till what all the effects are there, we can call it as pharmacodynamics. So to understand pharmacodynamics, we'll just try to understand the basic concept first, that is how the drug is there within the body. So suppose you think that you plan evening walk with your boyfriend or girlfriend. So the evening walk will be for spend some time in the college campus, then go for a movie, then go for a dinner. Okay, so with these 3 points, we'll understand that once you are in the college campus, so you may be happy, you may be having the snacks or chats, and then you'll go to a movie. First is the movie. So whether you can talk there, you are not able to talk there, or his or her mood is good or not, you don't know. In the movie, you go there, you can chat there, his or her mood is good or not, you don't know. Then you go for a dinner, then either you want to take a food or not, you don't know. But all these 3 times you are together. Okay, so in the same way, here, when the drug is there in the body, the first thing what you are seeing here is a system within the body is present in the body in the systemic circulation. Here the drug may be in the bound form or in the free form. Okay, so the bound drug will not be able to act. Okay, the bound drug means here it may be bound to the plasma proteins. Okay, then at the site of the receptors also, if the drug is there inactivated form or it is associated with the carrier protein where it may not be able to readily act. Once it is free from that, it will be able to act. So at the locus of the action or at the site of the receptor, for example, if iron is a drug here, so it is carried out in the form of apoferritin. Okay, or it can be there in the tissue reservoirs in the form in the tissue reservoirs. This iron can be associated with in the form of hemosiderin. Okay, so in the free drug will be ferritin form. Ferritin form in the systemic circulation. When it is mobile, it can be in the form of that is association with the apoferritin, or in the tissue reservoirs it can be found in the form of hemosiderin. So here the drug, even though it may be present in the tissue reservoir or in the systemic circulation or at the site of the receptors, it may not be freely acting all the time. Okay, it may be in the bond form or free form. That is, even though you are at the campus, even you are at the site of movie, or you are at the hotel taking dinner, it is always the good mood where you are enjoying the happy time, or you are in the upset mood, we don't know. Or here the drug is acting, or here the drug is not acting, we actually don't know. And most of the time it depends on various factors. Other than that, if we come to the ADME or pharmacokinetic part, here you can see the absorption part, metabolism, distribution part will take place in the pink box which we are given here, and the excretion part there. So that pharmacokinetic part, most of the time it is a little bit predictable, and the dynamic form is still dynamic concept for us. So why we should learn about this pharmacodynamics? So for the better assessment of the new modalities of using the drug, here the new modalities of using the drug, for example, if the drug is bound to preventing from excretion, we have something called as the liposomal amphotericin, where the drug is made to stay in the plasma by making it more attached to this liposomal or the nanoparticles, and we are making it bioavailable for longer time. Then better assessment for new indication for this drugs. Then better assessment of new concerns about risk and benefit. If the drug is staying there in the long time in the body, what will be the demerits? For example, if you take the iron preparations, which is the example which we started. So here, if the drug is there in the long time, it can be causing some iron pollution diseases that can be there. Or if the drug is not absorbed in the body, that it can they can be excreted in the form of malignant. So there are, if the blood cells are not able to uptake it, it is not stored. Then the excess of iron which is there, it can be excreted out like that. So we should always be able to assess the risk and the benefits. So here, the first concept we have to learn here is about the molecular pharmacology, or the how the concept of this pharmacodynamics evolved. So before understanding the molecular pharmacology or pharmacodynamics, we will be learning this pharmacodynamics under 4 headings or 4 subtopics. What are those 4 subtopics is? The first thing we learn in pharmacodynamics is about the receptors. On what receptors the drug is acting, and how long this drug receptor interactions will be there. What are spare receptors? All those things will be the one of the important topics. Then we learn about the what are the various adverse drug reactions which you can get, and then once the drug is bound to the receptors, how effective the drug is bound to the receptors, or we try to put a log dose response curve, or the concentration dose response curve. That will be the one more concept we will be learning. Okay. So basic concepts are learning about the receptors, log dose response curve, and the adverse drug reactions. What are the various type of adverse drug reactions we can get, and how we should be able to cope up with it, and what are the different types of adverse drug reactions we are getting. All those things will be learning in pharmacodynamics. So coming to the basic concept, that is, the drug will act on some receptor. Based on the receptor action, the drug will be able to produce the response. That is the basic concept. So that basic concept was put by Paul Ehrlich. You can see the photo of the person, Paul Ehrlich. So here, the basic concept, that is a receptor on which the drug can act, was given by him. Does that mean that the drug will not be able to act without the receptor? No. Okay. So the non-receptor mediated drug action itself is a short note for you. That means the drugs can also act without receptors, and there are many such reactions available within the body. So maybe we have given around 8 to 10 such examples where the drug will not be acting on the receptors and they will be bringing about some actions. So here, most of the time, the drugs are formulated based on its action on receptors. Okay. So this is the idea. So the idea of the drug act on specific sites was first put forward by Langley, but the concept receptor was put by Paul. So here, Paul Ehrlich is known as the father of modern pharmacology. Okay, so he is the father of this molecular pharmacology, who started with the concept of receptors, and he made more than 600 attempts before the first use of the successful drug which can act on the bacteria. So the drug which he found out was named as salvarsan, or it was a kind of dye which could act on the bacteria. So he failed in his 605 attempts, and the drug salvarsan was named as 606 or numbered as 606. He was the person who would never give up, and he proved himself to be worthy of Nobel Prize. He got Nobel Prize for physiology or medicine for this concept of receptors or the molecular pharmacology. So coming to the next concept, that is receptor binding. What is this receptor binding and how it will be able to act? So the first, you think that there is a horizontal line which is showing that the concentration of as the concentration of the drug increases, the drug response may increase. Then we have this percentage of the drug which is bound or unbound. Okay. Bound or non-bound, here we are in relation to the receptor we are speaking. Okay. There is one more concept, that is where percentage bound. We use it in case of the plasma protein binding, where the plasma protein binding can actually decrease. Okay. So here, as the drug goes on, concentration goes on increasing, or the bound to percentage bound to the receptor goes on increasing. Here we have higher the biological response we are getting. Okay, or here as the concentration is going on increasing, the drug action is also going on increasing. So this is the straightforward effect which we not commonly see. Okay, so there are many other concepts also which will tell more about this. Okay, so but this is the straightforward concept. The straightforward concept is as the concentration of the ligand increases, or as the concentration of the ligand or the drug or the biological amine goes on increasing, the percentage bound to the receptor will go on increasing, and the response to this drug will go on increase. This is the straightforward concept. So then we have the concept. Okay, the effect of drugs is mainly based on the two concepts here. Okay, what is that concept? The basic first concept is affinity for the receptors. So affinity is related to potency. So what is this affinity? Affinity is the ability of the drug or the biological amine to bind to the receptor. That is affinity, or the love towards the receptor. We can take it as a simple term. Affinity is something like a capacity to bind with the receptor. Okay. So affinity is related to potency. What is this potency? Potency is the ability of the drug to produce a response. Okay. So what is this potency? To keep it simple, we have two concepts here: potency and efficacy. So most of the time we tell this potency and efficacy in terms of number of students passing first year and coming to the second year. Okay, so all those students who are able to produce more than 50% of the marks in the class are known to be potent. Okay, So if we apply the concept of receptor or the receptor potency to the class of this second BDS, we can put it as all those students or all the students who are able to produce 50% marks will be coming to the second year. So now all of the second year MBBS BDS students are potent. Okay, all of the second BDS students are now potent because they were able to produce 50% and get through the required marks and come to the second year BDS. In the same way, the efficacy is the topper of the class. Among the second BDS students, who the person who has scored maximum marks, the person who has scored the maximum marks will be the more efficacies of the class. Okay, the topper of the class. Okay? So we call it as the topper of the class. So efficacy is once binding to the receptor. So what is the maximal effect the drug can elicit? Okay, what is the maximal effect the drug can produce? So what it so happens that year after year we get so many new drugs in the market. Okay, year after year we get so many drugs in the market. You know at least about 10,000 of the drugs we test in the labs every year. And on this, those drugs, for example, we compare it with paracetamol. So now we have a new drug which can reduce the fever. The first basic point we put is whether it will be able to reduce the fever as much as paracetamol. Okay, then we call it as potent drug. Then after that, whether it is able to produce more response or better response than the paracetamol at lower dosage also. For example, the new drug X, which is introduced in the market, is equal to 10 milligram of new drug is equal to 100 milligram of paracetamol. 50 milligram of the new drug is can produce 500 milligram effect of the paracetamol. Then if we put it under more efficacious drug. Now we will stop using this paracetamol and we'll start using the new drug because new drug dosage is less. So dosage is less means the adverse effect is less, and the adverse effect is less. The dosage is less means the production cost will be less. Okay, so everything will carry over. Okay, so that's why we will choose the maximum efficacious drug. Okay. As like most of us choose Apple phone over the rest of the phones. It is something similar to that. So it is efficacy. Though all of the phones will be able to use it in the optimal way, but the more efficacious one, which will not hang on, which can stay there in the long calls, all the benefits of user applications, everything will be now the most efficacious is Apple, like that. So coming to the next one, agonist and antagonist concept. Okay, agonist and antagonist concept. So the first thing we learned now was potency, efficacy, agonist. Okay. So agonist, what is this agonist? Agonist is affinity for the receptor. That is the drug which can bind to the receptors in the optimal way. That is the agonist. Agonist is a drug which can act on this receptor and produce an effect. But the antagonist is one more drug which has affinity but no efficacy. Okay, just now we learned that with binding is also there, efficacy is also there, that is agonist. Antagonist is a drug which has affinity but it has no efficacy. So that is the antagonist. Among these antagonists, we have two types, that is competitive antagonist and non-competitive antagonist. So what is the use of this antagonist when we have agonist? So most of the time, rather than agonist, we use antagonist more commonly. So you will be understanding why we will be using that. So there is one more concept that is called as partial agonist and partial antagonist. Has affinity but lower efficacy than full agonist. So to To understand this better, we have one more diagram. Okay, so here we have a x-axis and a y-axis. In the x-axis, we are going on increasing the drug dosage. In the y-axis, we are seeing the response. In the y-axis, we are seeing the response. X-axis, we can take it as a horizontal line. Y-axis, we can take it as a vertical line. So the first concept is full agonist. Full agonist is the maximum drug, the drug with maximum amount of drug which can produce full efficacy. So here we are actually not considering how much amount of drug we are. So we are giving the drug as much as possible till the drug produces maximum effect. So that's why we are seeing here that the response is somewhere around 150 full agonist. Okay. Then we have this concept of partial agonist, where the affinity is there, affinity for the receptor is there, but it is not fully efficacious. Whereas the antagonist doesn't can bind to the receptor, but has less efficacy or zero efficacy. That is antagonist. Then there is one more concept, that is inverse agonist, where the drug can produce negative effect than the expected positive effect. So we have two concepts, agonist and antagonist. Okay, among the agonist, we have two concepts, that is full agonist and partial agonist. Okay, here the affinity remains the same. Okay, affinity remains the same. Whereas in case of antagonist, what is happening is affinity is same as that, but in the opposite direction, or the efficacy here is zero. Then inverse agonist is a concept where the drug can produce negative effect than the expected. Okay. So here the response to the agonist and antagonist. So what I am trying to explain here is the first line is a red line, second is a orange and a green line. Okay, so here to understand, even though when the concentration of partial agonist, even though it is given at the maximum, okay, you can see here the concentration minimum when it is 10, the occupancy of both the drugs will be at the median level. But the line of response in case of agonist is somewhere higher here. Okay, you can see the arrow somewhere higher in here. That means the response will be more than 100 or something like near 100. If you can see here, the partial agonist, the maximum response is somewhere reaching around 50% of the efficacy. That's what we to understand the concept of partial agonist. Okay, partial agonist will not be effective that much. Then coming to the concept of inverse agonist. So inverse agonist can exist where the appreciable level of activation may exist even when no ligand is present. For example, there are a receptor can stay in 2 to 3 stages. One is inactivated stage, active stage, or the open stage. So what is this active stage or open stage? We will be learning. So the concept is there for benzodiazepine channels. Okay, so the benzodiazepine channels has a chloride gated channels or ion channels like. So the chloride will be normally moving, but when we add agonist, the chloride movement will be increased. Okay, in case so the concept of inverse, to understand the concept of inverse agonist, we have taken the receptor that is benzodiazepine. So in benzodiazepine, there is a open ion channel, okay, where the chloride will be normally moving across the ion channel. When we add this benzodiazepines, the chloride movement will be increased. Okay, the benzodiazepines will be agonist. So there will be some other drugs which can actually partially increase in case of this partial agonist. Whereas the antagonist of benzodiazepine, like flumazenil, the movement of chloride ion will be almost stopped. So that will be the inverse agonist. So there is one more concept, that is competitive antagonist. Okay, what is this competitive antagonist? So competitive antagonist is the drug and the antagonist, they both bind to the same receptors. Okay, in case of competitive antagonist, the drug and the agonist and antagonist both bind to the agonist and the antagonist, they both bind to the same receptors. And here, when we go on increasing the concentration of the agonist, okay, here we are actually going on increasing the concentration of the antagonist, there will be same amount of response will be there, but at a higher concentration. Okay, in case of competitive antagonist, we meant to say that if agonist is used, for example, at 100 milligram, antagonist is used at the 100 milligram, the response will decrease. But if the agonist concentration is increased to 200 and the antagonist remains at 100, now competitively the concentration of agonist is increased. So here we can get a parallel shift in the drug response. Okay, this parallel shift in the drug response, the maximum response is same. Okay, the maximum response is same. So here the same response is there, but at a higher concentration. Okay, the drug concentration is increased here. Okay, so that's what we mean by competitive antagonism. So here the comparative chart for the non-competitive antagonist. So in case of this non-competitive antagonist,
Excuse me, sir.
huh?
So the slides aren't changing, sir. It's still in the first slide.
Slides are not changing. But your net may be slow. No? I am reading the slides.
No, sir. I think for everyone, it's not changing. Anyone else? You can unmute or put it on chat.
Yes.
It's not changing, sir.
It's not changing, sir.
Yes, sir. And it's not audible also, so your voice.
Yes, sir. It's a bit. It's not very clear.
It's not changing, sir.
Slide is not changing. Yeah? What slide you are seeing?
The first slide, pharmacodynamics 1 introduction.
First slide, sir.
First slide, sir.
Okay.
First slide, sir.
Okay, now it is changing.
No, sir.
No, sir.
No, sir.
Yes, sir. It's coming now.
It's coming. Yes. What slide
Yes,
you are
sir.
seeing now?
So the third slide,
Okay.
free drug and bound drug.
Now you are seeing the free drug.
Bound drug, systemic circulation, sir.
Okay, now it is changing. Better assessment of new modalities you are seeing.
No, sir.
Okay.
Yes, sir. Now it's importance of learning how drugs work.
Okay, so I'll continue with this like that. Okay, so did you see this molecular pharmacology receptors that is Paul Ehrlich has given? You are able to hear that about Paul Ehrlich?
Yes, sir.
Okay. So did you hear about what I told about the Paul Ehrlich? He got Nobel Prize in law. Yes. Then did you see this normal receptor binding slide? Okay, so this is the normal receptor, normal concentration of the drug. Here is the bound form, and the straightforward concept is as the drug concentration increases, the bond form increases, the response increases. Is it clear now? Okay. So next slide I told about is potency and affinity. Okay, potency and efficacy I told. Hope I was clear about this potency and efficacy. Then I told you about this agonist, what is antagonist, what is competitive antagonist and non-competitive antagonist. The concept is clear. Okay. Then all of you can see. All of you can see about this full agonist and partial agonist. Yes, anyone respond? Receptor
Yes, sir.
Yes, sir.
This diagram you are
Yes,
able to
sir.
see. Okay, so I explained about the full agonist, partial agonist, antagonist, and the inverse agonist. So the positive response, which is when the agonist achieves full concentration or the maximum concentration, we get a positive response. In case of the partial agonist, even with the maximum concentration of the partial agonist, we get a response somewhere around 50% or less than the full agonist. Then antagonist, we told that the affinity is there, but the efficacy is not there. Okay, antagonist, if affinity is there, efficacy is not there. In case of inverse agonist, affinity is there, efficacy is also there, but it is in the opposite direction, even at its full concentration. So we use all type of drugs. Okay. Then we told that I have used a graph showing the response of the drugs in case of full agonist, in case of partial agonist. The green line, what we are seeing is the partial agonist, but the concentration of the drug, all the three can be at the 10 milligrams, but the efficacy here, the response of partial agonist is less, whereas the full agonist, the response is more than 100. Okay, then the concept of inverse, yes. Don't do that. Who is doing
ಚೇಂಜ್
that?
ಆಯ್ತಲ್ಲ
ಹೋದ್ರಿ ಇರುವಾಗ ಮಾಡೋದು
ನೋಡ್ಕ
ಕೇಳವಲ್ತೀಗ
ಇದು ತಗ ಕೇಳಿಸದ್ ಬೇಸ
All of you mute yourself.
ಮಾಡ್ತಾಗ
ಹೋಗಲೇ ಇನ್ನೊಂದ್ ಅರ್ಧ ಗಂಟೆ ಇರ್ತಾನೆ ಏನೋ ಕೇಳೋದ್ ನಾವೇ ಸ್ವಂತ
Yes, will you allow me to do the class? Capacitance, voltage drop will across your inductor, resistance, inductance, as well as your capacitance. So I am doing about the competitive antagonism. Here there is a parallel shift in the dose response when we go on increasing the concentration of the agonist. Okay, in case of competitive antagonism, both agonist and the antagonist, they bind to the same site. Here, after increasing the concentration of the agonist to double the antagonist, here the response, the maximum response can be obtained, but there is parallel shift in the drug response. This parallel shift is the increase in the drug concentration. When we are able to double the dosage or increasing the drug concentration, we will be able to get the same amount of response. This type of response we call it as the competitive antagonism. So those who are not able to hear or couldn't get the full class, I'll be sharing the video with you so that you can get it from your class coordinator, and you can also get the videos online. Okay, that whatever the class I have done. Thank you all.